All right. Well, good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today and pay my respects to their elders, past, present, and emerging. Firstly, a little housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you can submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. So today we're going to be hearing from Kerry Hwang. Kerry is a research assistant with the Melbourne Aging Research Collaboration and the National Aging Research Institute. His main research interests involve improving the lives of older people from culturally and linguistically diverse backgrounds. Today he's going to be presenting Avoiding Preventable Hospitalisation Admissions in Older People Living with Dementia, an analysis utilising Victorian hospital datasets. So welcome, Kerry, and over to you.
Thanks, Jess, very much for that introduction. And I would also like to endorse the welcome to country and also quickly acknowledge the traditional landowners on which I'm broadcasting my presentation from, which is also the Wurundjeri Woi-wurrung people. And I would also like to pay my respects to their elders past and present. So it's been a while since I've done one of these NARI seminars, so it's always good to be back and presenting. And today I'll be presenting on a project that's titled Avoiding Preventable Hospitalisation Admissions in Older People Living with Dementia. And we'll be looking at an analysis that utilises a number of Victorian hospital data sets. So really just to set the background a little bit, older people are more likely to encounter or utilise the hospital system as a result of chronic conditions as well as comorbidities as they age, particularly when we're looking at older people living with dementia. But unfortunately, hospital systems and environments can have deleterious effects on older people, particularly those who are living with dementia. And not all hospitalization events are unavoidable. Many of them can also be avoidable if you manage the conditions or treat them conditions in the community setting through primary healthcare pathways. But some of the factors and predictors that result in avoidable hospitalization admissions in older people living with dementia aren't really well understood. And so it makes it very difficult to then target and identify solutions and strategies that might help. So really the purpose of today's presentation is to go through some of the preliminary findings where we sort of explore what some of the patterns and predictors of preventable hospitalized admissions in older people living with dementia that are admitted or presenting to Victorian public and private hospitals might be. So before I continue, I would also just like to quickly acknowledge the MARC project partners for this study, which were the National Aging Research Institute, Deakin University, the University of Melbourne, and I would also like to just acknowledge the funders who were the Melbourne Aging Research Collaboration and the State Trustees Australia Foundation as well. So the statistics show that in 2016-2017, 6.5% of all hospitalizations in Australia could have been prevented if the conditions were managed earlier. And these sort of hospitalizations or events are known as ambulatory care sensitive conditions, and they come in three broad categories. So these include vaccine preventable, such as influenza, acute treatable conditions, including dehydration and gastroenteritis, as well as chronic manageable conditions, including asthma and diabetes. And though some of these conditions may have exacerbated to the point where at the point of presentation or admission, their conditions may be considered an unavoidable hospitalization event, they're considered avoidable because all of these conditions can be managed or treated or prevented through primary healthcare pathways, particularly in the community. Hospitalization due to ambulatory care sensitive conditions are also known as potentially avoidable hospitalization. So you'll probably hear me using both terms interchangeably. So just be aware that ambulatory care sensitive conditions are also known as potentially avoidable hospitalizations. And they're actually quite typically used as an indicator of access to primary health. And when you look at the literature around mechanisms to reduce avoidable hospitalization admissions and presentations, a lot of the literature is really focused about improving access to primary healthcare services. So in terms of the statistics for older people, unfortunately, depending on the sources, older people make up approximately 14 to 27% of all potentially avoidable hospitalizations. And what's really unfortunate is that potentially avoidable hospitalizations are really, really common in people living with dementia compared to the general older population. And as a result, when you compare them to their age-matched peers, they also have significant greater risk and susceptibility of ambulatory care sensitive conditions. And some of the reasons for that include the fact that they're more likely to have other long-term health conditions or comorbidities, such as diabetes or cancer. They're also less likely to access and receive primary health care, and also more likely to be prescribed psychotropic medication, which can really have a significant impact on the way they manage their comorbid conditions, in addition to dementia. And as a result, they also have twice the overall rate of hospitalizations. And when you actually think about the hospital environment, it can be a very stressful environment, and it can also be, a very sensory environment as well. So when we think about the hospital setting, they can be very, very noisy with many emergency alarms going off, the sound of machines beeping, conversations, people coming in and out. So they can be very noisy. They're also very, very busy. Lots of medical staff moving about, coming in and out. Same with the visitors as well as patients coming in and out. Very busy environment. And the patient may also be moved from different places as well. And also, some staff may lack the dementia-specific training. So they may have the lack of specific dementia skills to be able to look after and treat the older patient living with dementia, as well as their carers. And as a result, when you think about it, it's really unsurprising that older people living with dementia are really at greater risk of poorer outcomes during the hospitalization event. And of course, there's been a lot of evidence and literature trying to explore what some of those negative consequences or poor outcomes of hospitalization in older people that are living with dementia might be. And as an example, there was a large study that was conducted in New South Wales, which looked at over 400,000 hospital episodes for people aged 50 years and over. And they found that when you control for age, sex, and medical comorbidities, medical and surgical patients with dementia had significantly more complications. And here are just a list of some of the complications. So medical patients with dementia compared to their age-matched peers had higher rates of delirium, urinary tract infections, pressure ulcers, as well as complications leading to death. When they looked at surgical patients with dementia, they found that they had higher rates of delirium, urinary tract infections, pressure ulcers, hospital-acquired pneumonia, metabolic derangement, and gastrointestinal bleeding. So really a strong epidemiological study to show some of the really poor outcomes as a result of hospitalization in older people living with dementia. And of course, some other studies have highlighted that older people living with dementia are 2 to 3 times more likely to experience an adverse event, and some of those which I've covered in the previous slide. They're also unfortunately more likely to be transferred to an aged care facility upon discharge. And they are also twice as likely to die during their hospitalization event as well. And of course, hospitalization also has a fiscal impact upon the hospital and healthcare system. And it's estimated that the total cost as a result of avoidable hospitalization events is approximately 43 million Australian dollars. And when you look at the per cost of hospitalization of older people living with dementia compared to the age-matched peers, their per episode cost of hospitalization is nearly $3,000 more compared to their age-matched peers. So obviously, the last couple of slides have gone through some really significant poor outcomes as a result of hospitalization on people living with dementia. So given these risks, it's really important to try and reduce any sort of levels of unnecessary hospitalization events so you can reduce all of these negative impacts on older people living with dementia and ensure that they only encounter the hospital system when they need it the most. However, the factors that lead to potentially avoidable hospitalizations in older people living with dementia are not really well understood. And again, I'll sort of reiterate what I discussed at the start, that it then makes it really difficult to identify targeted solutions and strategies to reduce the overall rate of avoidable hospitalization admissions in older people living with dementia, and then subsequently reducing a lot of these flow-on effects, including poor outcomes for older people, as well as the fiscal impacts as well. So this isn't the first time that the Melbourne Aging Research Collaboration has looked at this problem. And there was an earlier study that was called Preventing Avoidable Hospitalization Admissions, called the PAHA project. And this was a really neat little sort of bit of a scoping study where we looked at a few different things related to avoidable hospitalization admissions in older people living with dementia. And so some of the objectives that the PAHA project seek to answer was to understand the prevalence and reasons for avoidable hospitalization for people living with dementia living in the community, to explore practices and attitudes of staff working with people with dementia, as well as their carers who attended the ED, and also to explore the effectiveness of interventions targeted towards carers in reducing hospitalization in people with dementia. And just for that last point, the hypothesis behind that was sort of the thinking that due to overwhelming carer burden and carer distress from providing care to an older person living with dementia, instead of trying to seek out the appropriate primary healthcare services to sort of alleviate some of the medical health concerns of the older person living with dementia, they would just sort of send them to the ED as desperation. So with that research objective, that's what we were really trying to explore and understand what was happening there. This study was broken down into three parts. The first one was an audit, which was a retrospective audit of 150 emergency department records of people living with dementia who were living in the community across 3 Melbourne emergency departments. So it was an audit of emergency department presentations, and the people who were reviewing this audit were essentially emergency department staff. And so there were approximately 50 records that were audited at each site. The second part was a survey that was completed by 24 staff from 2 Melbourne hospital sites regarding the practices and attitudes towards people with dementia, as well as their carers who attended the emergency department. And finally, a systematic review, which is still ongoing, really aimed to try and address the effectiveness of carer interventions in reducing avoidable hospitalizations of people living with dementia. So what did this earlier study find? Well, from the audit data, we found that pain and falls were the most common reasons for presentation, and that on retrospective review, most presentations were considered avoidable at the time of presentation. But a large proportion of emergency department presentations were considered to be avoidable in the days or weeks leading up to that emergency department presentation. From the survey, an overwhelming majority of staff, or 96%, agreed that hospitals were a risk to people living with dementia, which concurs very nicely with a lot of the literature and evidence that I presented earlier on as well. In addition, quite a large percentage of the survey respondents, 87%, reported that people living with dementia are a major problem for the healthcare service. And I guess it sort of just emphasizes the point about that some staff may lack the dementia-specific training, but also it's a little bit of a perception that older people living with dementia are a bit burdensome, and there's a bit of a pessimistic sort of attitude towards that. And staff also identified that carer education and support is likely to improve access to community services and is likely to prevent hospitalization. So from the systematic review, which again, I reiterate is still in progress, we found that carer interventions appear to have a short-term impact on carer well-being when we're looking at measures of carer burden and carer distress. But if we're looking at the association between carer interventions and the rate of hospitalizations for people living with dementia, we found that really didn't have an impact on the rate of hospitalization presentations on older people living with dementia. So really, just to summarize, most presentations were considered avoidable in the weeks leading up to the presentation, and that the most common types of avoidable presentations were pains and the most common types of presentations were pains and falls. Staff recognized the risks of the hospital environment on people living with dementia and the apparent burden it also causes for the healthcare system. and that the systematic review revealed that care interventions appear to have little impact on the rates of hospitalization for people living with dementia, but of course they do have an impact on the overall carer well-being. So just moving on, while the original PAHA study was a really nice study, just looking at various different factors and perhaps also looking at what are some of the predictors or patterns of avoidable hospitalizations to emergency departments. The audit, I guess, which is really the main focus, was quite small scaled. And of course, it can also be very difficult to accurately determine patterns of emergency department presentations, as often dementia is not coded as part of the presentation. And therefore, if we want to explore patterns and predictors, we need to have a more accurate way of identifying people with dementia presenting to emergency departments and also at hospitals as well. So one way we can do this is that we can use existing hospital data to predict the patterns of avoidable hospitalization in people living with dementia. And sort of by analyzing hospital data, it might actually provide clues on where solutions and strategies might be most effective in reducing avoidable hospitalizations in older people who are living with dementia. So that really was the purpose of this study. It was to identify and analyze the patterns of avoidable hospitalization presentations and admissions in older people living with dementia. And so this project had two research objectives. The first was to identify the most common ambulatory care sensitive conditions in older people living with dementia that were being admitted into public and private Victorian hospitals. And also, what are the predictors of ambulatory care sensitive condition admissions within hospitals, and as well as presentations to emergency departments. So this research project was approved by the Deakin University Human Research Ethics Committee. And just to explain some of the data sets that we analyzed. So we analyzed two Victorian hospital data sets. The first one was the Victorian Admitted Episodes Dataset, or the VAED, as well as the Victorian Emergency Minimum Dataset, or the VEMD. And we analyzed the hospital data sets for the 2015 and 2016 financial year. So both of them contain de-identified demographic, administrative, and clinical data, but the scope of the data sets is different. So the VAED covers data of all admitted episodes in public and private hospitals, but it also includes data from rehabilitation centers, extended care facilities, and day procedures as well, day procedure centers as well. Whereas the VEMD contains data only from emergency department presentations at Victorian public hospitals, so not private. And there's a few other ones that are directed by the Department of Health. And just to sort of put this into the back of your mind when we're looking at the results a bit later, that the scope of the two data sets is different. So the admitted episodes is only looking at admitted and not presentations. And of course, the Victorian Emergency Minimum Dataset is only looking at emergency department presentations. So you might find that when I go through the results, some of the results might not concur with each other when we compare the two analyses. But part of that can be explained by the fact that we are looking at slightly different scopes of the sample population. So just in terms of the data analysis, we analyzed the two data sets separately. So for the first analysis, looking at the admitted episodes data set, we wanted to explore the patterns and predictors of ambulatory care sensitive condition admissions. And we also wanted to look at what were the most common ambulatory care sensitive condition as well. So for the second analysis, looking at the VEMD, we explored triage category as a surrogate measure of ambulatory care sensitive condition in ED, emergency department presentations. And the reason why we're looking at surrogate triage category and not ambulatory care sensitive conditions is that it's not possible to accurately determine ambulatory care sensitive condition in emergency departments, because that data set only allows for up to 3 diagnosis codes, whereas the VAED allows for up to 40. So you're much more easily able to accurately identify ambulatory care sensitive conditions through the VAED as opposed to VEMD. But you can look at the triage category to see if it was an urgent or non-urgent triage category as sort of like an informal measure of ambulatory care sensitive conditions, emergency department presentations. And both of these analysis was done using multivariable logistic regression analysis to look at the odds of the admission or presentation being either non-urgent or a potentially avoidable hospitalization event. So just to go through the first analysis in a bit more detail, looking at the admitted episodes data set. So the outcome of interest was hospital admissions and whether they were classified as an ambulatory care sensitive condition or not. And the way that we determined whether the admission was an ambulatory care sensitive condition was that we classified them according to the Australian National Healthcare Agreement, PI 18 selected potentially preventable hospitalizations. And they basically go through which types of diagnosis and how many types of diagnosis and the conditions that would classify that specific admission as an ambulatory care sensitive condition. So the factors that we wanted to explore included age group, gender, marital status, whether or not an interpreter was required, English as a preferred language, hospital admission source, as well as admission type. And the population that we selected was those who were aged 50 years old or older and with a principal of or additional diagnosis of dementia, using those ICD-10-AM codes that obviously code for the dementia-related diseases. And through this presentation, I've been talking a lot about older people. And of course, dementia does disproportionately affect older people more, but using the lower age gap also recognizes that there are people who are being diagnosed or suffering from younger onset dementia. So we wanted to capture that as well. And in addition, I also discussed in the earlier slide where I was going over through the data sets that the VAED includes public and private hospitals, but also admissions in other different types of healthcare services. For this analysis, we're only really interested in the admissions to public and private hospitals. So we excluded those that were admitted into other non-hospital type facilities. So this next slide is just goes through some of the results. And what this table describes is the hospital admissions in older people living with dementia, categorized by our outcome of interest. So whether or not the admission was classified as an ambulatory care sensitive condition or not. And so in the 2015-2016 financial year, we identified 8,156 admissions of people living with dementia, I should say. And under half, or 47.62% of those were considered to be a potentially avoidable hospitalization admission or an ambulatory care sensitive condition. So if we're looking at just those hospital admissions that were considered to be an ambulatory care sensitive condition, and we break them down by categories, we see that the most common type of ambulatory care sensitive condition are chronic conditions, which accounted for over half, of 56.28% of all of the hospital admissions of people living with dementia, followed by acute, which accounted for 42.56%, and vaccine preventable accounted for a very, very small percentage, or 1.16% of all ambulatory care sensitive condition admissions in the 2015-2016 financial year. When we look at specific conditions, we see that urinary tract infections and diabetes complications were the two most common ambulatory care sensitive condition admissions. And of course, both of these are relatively common in not only older people, but also older people living with dementia. And of course, diabetes is often a comorbid condition along with dementia. Some of the other common ambulatory care sensitive condition admissions included hypertension, COPD, congestive cardiac failure, as well as cellulitis, conditions that are also more common in older people as well. So moving on to the results of the multivariable logistic regression of ambulatory care sensitive condition admissions. This table outlines the odds of being admitted to hospital with an ambulatory care sensitive condition in older people living with dementia by the specific factors. And because this is multivariable, each of the factors is controlling for the other one. So you're not getting any potential bias from the other variables. When we look at gender, age, and marital status, we don't see a difference in the odds of being admitted to hospital with an ambulatory care sensitive condition. But when we looked at English as a preferred language, we see that those who had English as their preferred language had a 23% lower odd of being admitted to a hospital with an ambulatory care sensitive condition in older people living with dementia. So I guess this sort of says, you can sort of interpret this as those who are from a linguistically diverse background are more likely to be admitted to hospital with a potentially avoidable hospitalization admission. We didn't find a difference when we looked at whether or not an interpreter was required, but when we looked at, and there was no difference when we looked at the geographical location of the hospital as well. When we looked at admission source, those who admitted from another facility other than a mental health or, those who were admitted from another admission source apart from an aged care facility or a private residence had a 57% lower odd of being admitted to hospital with an ambulatory care sensitive condition. And finally, those who were admitted through a non-elective admission had a 65% higher odd of being admitted to a hospital with an ambulatory care sensitive condition. And I guess this is really unsurprising because obviously if the admission was elective, then it wouldn't be an unavoidable hospitalization event. So moving on to analysis 2. So this analysis looking at the emergency department presentations, so not admissions. The outcome of interest was whether or not the presentation was assigned as a non-urgent triage level category. And I think triage categories can change depending on which state or which country you're working from. But in Victoria, there's 5 triage levels. So if the presentation was triaged as level 1, 2, or 3, representing immediate emergency and urgent, these are obviously very life-threatening presentations. So they were classified as not a non-urgent triage level category. And if they were semi-urgent or non-urgent, then they'd be classified as a non-urgent triage level category. So we basically created a new variable, which would then become the outcome of interest. So the factors of interest that we want to see whether or not they had an effect with the urgency of the triage level, I guess, of emergency department presentations as a surrogate measure of whether the presentation may or may not have been an avoidable hospitalization event, included gender, age group, country of birth, accommodation, the referral type, whether or not an interpreter was required, and whether or not the English was the preferred language. And similarly to the first analysis, we selected the sample population was those aged 50 years old or older, and a principal or additional diagnosis of dementia. So this table goes through the multivariable logistic regression of the triage categories. And this is looking at the odds of whether the presentation to the emergency department in a Victorian public hospital was assigned to a non-urgent triage level in older people living with dementia. So what we can see here is that being female, so those who were female had a 6% higher odd of their presentation being assigned to a non-urgent triage level category. So and there's a few explanations for that. So we know that gender health studies have revealed that women are more likely to utilize healthcare services than men. So it's also perhaps a little bit unsurprising that perhaps women are more likely to use emergency departments or be presenting at emergency departments than men. But there's also some evidence that perhaps there's a bit of gender discrimination going on, that in some specific conditions, such as cardiovascular disease, that the symptoms of, for example, the symptoms of cardiovascular disease are not as taken as seriously as men's. And if they turn up with, a cardiovascular complaint or turn up with a complaint, they might be inadvertently assessed as non-urgent, even though their condition might actually be urgent. We didn't find a difference when we looked at age. Those who were born in Australia had a 10% higher odd of their presentation being assigned to a non-urgent triage level compared to those who were not born in Australia. And this result looks a bit funny when we sort of compare it to the other culturally and linguistically diverse related factors. So just hold on to that thought for a minute and I'll come back to it. When we looked at the usual accommodation, we find that those who usually lived in an aged care facility were 17%, had a 17% lower odd of their presentation being assigned to a non-urgent triage level compared to those who were living in a private residence. And I guess that sort of explanation for that one is the fact that, within aged care facilities, it's often frequently staffed, and any sort of health complaints might sort of be hopefully managed or more likely to be managed before they get to the point where they need to be hospitalized. When we looked at referral type, so those who had the referral type by staff, police, or nurse compared to self, family, or friends had a 9% higher odd of their presentation being assigned to a non-urgent triage level. And then when we look at sort of the linguistic factors, so those who required an interpreter had a 50% higher odd of their presentation being assigned to a non-urgent triage level category compared to those who didn't need an interpreter. And those who had English as their preferred language had a 28% lower odd of their presentation being assigned to a non-urgent triage level category. So a lot of that concurs with some of the findings we saw when we looked at the admissions data sets. And just going back to the born in Australia. So what this sort of suggests is that when we look at the interpreter as well as the English proficiency, it seems like it's correlated variables that seem to predict an avoidable emergency department presentation of older people living with dementia. But the country of birth category sort of goes in the opposite way. And part of the reason might be is the fact that some of our largest migrant groups in Australia are actually those who are born in the main English-speaking countries, such as those from New Zealand, as well as the United Kingdom. And by sort of including them with our other countries of birth from non-English-speaking backgrounds, this might sort of change the association a little bit or muddy it a little bit. So again, this is preliminary analysis. So one of the things we might do when we sort of reanalyze this data a bit is sort of either break it down into tri-country variables, born in Australia, born in main English-speaking country, and those born in sort of like non-main English-speaking country, or just break it down by whether they were born in English or a non-English speaking country, just sort of have a relook at that analysis again. But I guess it also really hammers home that there does seem to be a lot of barriers, particularly for older people living with dementia and those that are coming from culturally and linguistically diverse backgrounds. So in terms of the summary of the two analyses, nearly half or 47% of hospital admissions in older people living with dementia were considered to be ambulatory care sensitive conditions. The most common ambulatory care sensitive condition were diabetes complications, as well as urinary tract infections in older people living with dementia, and that perhaps across the two analyses, cultural and linguistically diverse factors are associated with avoidable hospitalization admissions, as well as presentations that are assigned as a non-urgent triage level in emergency departments. So what are the consequences of some of this research? What are some of the tangible effects that we can gather out of this analysis? So first of all, I've talked a lot about, particularly in the introduction, how improving access to primary healthcare services, particularly in the community, is really a strong focal point of trying to reduce unnecessary hospitalization events and potentially avoidable hospitalizations, particularly just in the general population. And so when we look at perhaps the two most common conditions, that if we can somehow improve the management treatment of dementia and urinary tract infections, particularly with a focus point in older people living with dementia, then it's likely that we are able to reduce the rate of ambulatory care sensitive conditions that are classified as an urinary tract infection or a diabetes complications, particularly in older people living with dementia. And also through the regression analysis, we also identified a lot of cold factors, that culturally and linguistically diverse factors that might predict the admission or the presentation as sort of like a non-urgent or avoidable hospitalization event. And obviously, we really need to address those barriers, particularly within the community and primary healthcare service level. And of course, there's a lot of literature out there to say that older people from culturally and linguistically diverse backgrounds do experience significant barriers to access accessing primary healthcare. And there's also a lot of evidence to show that dementia is also very stigmatized within certain migrant groups, and that there's also a lack of dementia-specific healthcare services as well. So perhaps a stronger look at providing and improving culturally and linguistically specific and appropriate dementia healthcare services is also potentially likely to reduce avoidable hospitalizations in this population as well. And of course, there's sort of always some further questions that can be explored. And I think sometimes with quantitative data, you're always looking at, you know, what's really causing and what's really causing the underlying numbers that you're seeing. And so I think while we've really illustrated and highlighted that cultural and linguistically diverse factors are really significant predictors, it should also be reasonable to try and stratify the analysis by cultural factors, because we haven't really looked at, we haven't really identified too many unique patterns or predictors of people that were born in Australia. So that's one thing we can look at to see if there's actually different factors that are affecting different cultural groups. The other thing that I sort of brought up when I was explaining, you know, the significance of the gender variable is that, you know, perhaps we need to understand the triage process a little bit better to see if there's, you know, there's sort of underlying discrimination that might be occurring that might sort of predict why certain people might be categorized into urgent or non-urgent triage categories. And also, I think that the hot word on everyone's lips in the last year or so has been COVID-19. So examining the effects of COVID-19 on avoidable hospitalizations in older people living with dementia is, I think, also warrants its own study. And I think it'll be really interesting to explore what sort of effect, you know, the whole public health response to COVID-19 has had on some of these avoidable hospitalization rates and events. And just moving on to limitations, because we're looking at an administrative data set, we're really limited to only what sort of variables and data were collected as directed by the data custodians. In addition, some of the variables that are captured may be inaccurately reported. So for example, I think carer status was one variable that was listed in the Victorian admitted episodes data set, but it's very difficult to record and understand the carer status at the point of admission. So it's very hard to look at that from a clinical and administrative data set. In addition, this is only Victorian data sets, so our findings might not be applicable in-state, nationally, or internationally, but a lot of our results do concur with some of the general findings in the literature. Dementia research is one of the 4 themes of the Melbourne Aging Research Collaboration. And of course, it's also an important research theme at the National Aging Research Institute. And I would just like to highlight some additional work that we're looking at in addressing dementia in hospitals. So the first one is called Dementia Friendly Emergency Departments, or the Defence Project, which is a MARC-related project. So the purpose of this project is to explore, implement, and evaluate evidence-based strategies to improve emergency departments for people living with dementia. And this project also has a co-design element with emergency department staff. So we really want to make sure that some of the research and the implementation that we want to sort of investigate is driven and led by the staff who stand the most to benefit. And if you want more information, please contact Dr. Kirsten Moore, and I've just listed her email there. And another project is looking at improving the management of patients with severe behavioral and psychological symptoms of dementia or BPSD in Victorian hospitals. So the purpose of this project is to explore the knowledge of the prevalence and impact of BPSD in Victorian hospitals, understand the current experiences of families and staff relating to the management of BPSDs within Victorian health services, and also estimating the point prevalence of people living with dementia being admitted to hospital using the VAED dataset. And if you'd like more information on that, please do contact Miss Sue Williams or Miss Amy Parker. And so thanks very much for attending. Again, this is preliminary analysis, so I'm very interested in hearing your questions and also comments as well. Thank you.
All right. Thank you very much, Kerry, for that presentation. We now have some time for Q&A, so if you have any questions, please submit them through the chat function. Alternatively, if you'd like to ask your question in person, you can turn on your camera and microphone and we'll call on you in turn. Kerry, would you mind maybe stop sharing your screen so we can see what in case people would like to ask questions?
Sure.
Now, Mandy, have you turned on your camera because you'd like to ask Kerry a question? Nope. Okay, sorry. All right, we have an initial question from Bryony. She asks, she doesn't ask, she comments, it looks like you have a good base for COVID-19 comparisons.
I agree. Yeah, I agree 100% with that, Bryony. So, and I guess I think sort of just to make another comment, I think the effects of COVID is probably going to be longer lasting. So, because this data is, I think, collected every year, I think the purpose of it's one for research and epidemiological data, but I think it's also used for funding. You can sort of kind of do a pseudo longitudinal study of it. So you can kind of, you know, track these sort of events sort of longitudinally. So you can sort of then sort of see what's been going on. And then once we hit 2019, 2020, what's happened afterwards. And then further on, if you're doing it 10 years further down the track, then you can sort of get a better understanding of the effects of the pandemic as well.
Bryony asks, are there any plans for asking people living with dementia and their carers about their experiences and what they would like to see?
Yeah, I think in the original PAHA project, that was one of the aims, but I think we just found it a bit difficult to try and recruit and get people, caregivers as well as care recipients to try and discuss about their experiences as well. The defense project, I think, also has a small element within it where they do want to interview a number of care recipients and caregivers after the co-design intervention has been implemented to see what their what their perceptions of that is. So yeah, nothing within this project just yet, but there's also a lot that's been done and that is going on in our other projects as well.
So Kirsten asks, comments that confirms that yes, you'll be interviewing a small number of family.
Thanks, Kirsten.
Yep. I'm interested, why did you include level 4 triage semi-urgent as a non-urgent triage level in your analysis?
So I didn't do the analysis. Another member of our research team did. I do have access to some of the preliminary analysis, and I think the reason was sample size, because I think the non-urgent was very, very small. So if you didn't include semi-urgent, then I think you couldn't run the regression model at all. Because we did run sort of like a univariable, so just the outcome of interest with an individual variable, not controlling for any other factors. And I think we did one for triage category. And when you looked at that, the last category, level 5, was omitted because the sample size wasn't sufficient for you to calculate. So I think it was sort of like we did it just to make sure that we could get the analysis up and running. And it's probably not ideal. And I think it, if it's semi-urgent, okay, you probably need to deal with it. But I think just for the purposes of analysis, we thought, okay, this is the compromise we need to make.
Thanks, Kerry.
Jessica, I was just going to add that the reason that we did that also was informed by the emergency department medicos, who suggested that was an appropriate cut point of what they see in clinical practice. So numbers reasons, but also just very practical reasons.
Good to know. So Joan asks, will you further investigate the potential cultural bias in ED? It's a concerning finding.
Yeah, I think it is a concerning finding. Francis, you have anything to add to that?
I think it raises a couple of issues. One is, recognition of dementia in emergency department presentations. It's not well coded for a number of reasons, but also that when people who are attending emergency departments, what consideration is given to those cultural and linguistic factors in terms of triaging and undertaking comprehensive assessments as soon as people come in the front door. So I think, there is a lot of work to be done around both the issues of dementia as well as diversity.
Do you have a question for Kerry? While she ponders that, I'll ask a question from Kirsten. She asks, why do many private and public nursing homes have a policy of sending people living with dementia into hospital if they've had an unwitnessed fall? I've been told that in case a person has experienced a head strike, they should have TB to exclude subdural hematoma. But with someone with dementia, are they not going to operate anyway?
Yeah, well, I think that's an interesting comment. I guess I think one of the conversations I've just dobbed in Francis because I've been deferring questions to her, but one of the conversations we've had is, I think it just feels like there's certain weighting, and this is sort of going back to the emergency department, but there seems to be specific weighting for the assessment of specific people who are coming from specific places. So I think it's interesting that, public and private nursing homes are being sort of sending people who are living with dementia into hospital if they have an unwitnessed fall, and then they're sort of, or maybe then being assessed as an urgent category. So there's more explanation. So for me, that's one side of looking at is how, sort of again, looking at how triaging is happening. So yeah, but I think that's kind of interesting, and perhaps that's a separate study itself. So why are they sending people who are living with dementia into the hospital? Yeah, so I think that's almost a separate but also related research question.
Kirsten, did you want to ask a follow-up question?
I was just going to respond to Kirsten. As far as we know, often these policies were driven by coroner's findings where there had been an unwitnessed head strike in residential aged care, and then a person had unfortunately died after their bleed was not recognised. And so as a result of coroner's recommendations, aged care facilities started policies of sending people in to get a CT of the brain, but obviously it's something that would need, a lot of sensitive discussions with family and so on to work out whether that's something that should be done or not. So yeah, as far as we know, it was driven by those coroner's recommendations, separate to this study that Kerry's just been talking about.
Thank you for that question, Kirsten. Aaron responds, it's a great point, Kirsten. There's a need for policy to take into account advanced care planning and goals of care planning. It's often, but it is often a risk-adverse environment. All right, Kerry, you mentioned that there were barriers to people who are culturally and linguistically diverse in primary healthcare. I was wondering if you'd like to elaborate on that at all. I'd be interested to know.
Yeah, I mean, I think sort of it's actually the topic of my PhD is trying to measure and identify them. So the literature has talked a lot about different types of barriers. So there's obviously culturally and linguistically related factors. So obviously the lack of culturally appropriate specific health, where I think interpreter was something that I talked about a lot, and trying to get interpreters with the right language can also be difficult because it's often undersupplied, and there's also a timing thing as well. So yeah, and there's also other sort of more broader macro health policy, so sort of not health policy, but just broader macro health reasoning. So it's health literature, cultural, even how long someone's been in the country, how familiar they are with the healthcare system. And there's also socio-demographic factors that are culturally different, so gender, marital status, stuff like that. So there's a lot of interlinking factors that could affect primary healthcare access. And I think particularly if you're looking at dementia healthcare services, lots of literature says that older people from culturally and linguistically diverse backgrounds, one, dementia is very stigmatized. Two, it's very a lot of the language around dementia isn't really well translated in many languages, which then feeds into the stigma. But there's also just a lack of culturally specific, appropriate dementia services. And I know Bianca is doing a lot around that area in trying to sort of reduce the stigmatism and trying to improve the awareness as well. So yeah, and I guess this research just sort of it kind of supports a lot of that that literature that is in that research field as well.
Great. Thanks for that answer, Kerry. Does anyone have any further questions that they would like to ask Kerry?
Yeah, I agree with Kirsten's comment there. Yeah, 100%.
Fantastic. Well, everyone, please join me in thanking Kerry with your clap reactions. It was fantastic to hear from you today.
Thanks,
next,
everyone.
we're going to be hearing from Joan Ostaskiewicz, who'll be presenting Beyond Containing and Concealing Incontinence, Unraveling the Nature of Continence Caregiving. So please join us next week on Tuesday, the 6th of, next week. And thank you for attending our Seminars in Aging program.